Hello, everyone. I'm Maria Theodoulou. I'm a breast medical oncologist up at New York Oncology Hematology, the program director of the breast medicine division. I am thrilled to be offering another chapter in our series of educational programs dedicated to our patients. This program is coming to everyone via a grant from Stacy and Richard Rosenthal, a very generous grant which has allowed us to move forward with these programs. Tonight, I am privileged and overly honored and excited to have a discussion with Dr. Neil Iyengar, who's an associate physician at Memorial Sloan Kettering Cancer Center in the breast medicine division, exclusively in the breast medicine division, also an associate professor at Cornell, and with an incredible research lab and program that he has been fostering at MSKCC, really looking at the link between obesity and breast cancer and exercise, and as it relates to preventing breast cancer, treating breast cancer, decreasing the recurrence risk, as well as our patients with stage 4 disease. So, Dr. Iyengar, I am so excited to have this conversation with you tonight.
Thank
And
you so much. It's such a pleasure to join you,
oh,
as always.
I'm thrilled. And let's just start off with that general question. What is the link between obesity and breast cancer?
Yeah, it's actually a very good place to start because that question we're learning is more complex than it would seem. I think that obesity is a term that we've been using now for quite some time, really to refer to somebody's standardized body weight by their height. In other words, the body mass index, which is supposed to sort of be a surrogate marker of your metabolic health. And when this tool was first developed, the body mass index, it was really meant to be a quick and easy way to understand how healthy at the metabolic level or unhealthy a population was. And it was really used in that way in research at first. And then it started becoming adopted as a personalized measure of metabolic health, as a way that we would assess individuals, and ultimately as diagnostic criteria for obesity, being a BMI or body mass index of 30 or greater. And so based on that initial foundation, and I think that's important foundation to put down here because I'm going to start to crack at that foundation. But based on that initial foundation, many groups, population scientists, recognized that those populations that had a higher body mass index on average, and typically in the obesity range, 30 or greater, had higher rates of developing many different types of cancers, what are now termed obesity-associated cancers. And there are at least 13 obesity-related cancers. Yeah, and that is based on a recent classification from the International Association for the Research of Cancer. And so, I think that this is an important recognition globally to understand that BMI is a direct risk factor for the development of several different types of cancers. But when we really drill down into the relationship between obesity and cancer, it turns out that obesity can act differently in different organs and different populations. And so what might be a obese range BMI for one population, for example, for a Western population, that's not quite the right cutoff, 30, for East Asian populations, for example. Or even some populations in Africa, where a higher BMI may be more indicative of lean mass. And so we have to be careful about how we use body mass index, and much of our research has really focused on how can we be more precise in terms of measuring a person's metabolic health. And I'll get back to that question in a minute, but ultimately, in terms of breast cancer, what we've learned is that the relationship between obesity and breast cancer is complex, even if you use the standard BMI term. So we know that a body mass index of 30 or greater is a risk factor for developing postmenopausal hormone receptor positive breast cancer.
So you just highlighted the word postmenopausal. So there's a clear difference obesity in a premenopausal patient and obesity in a postmenopausal patient. Is that what I'm understanding?
Absolutely,
Good.
absolutely. In fact, there are some data which associate a higher body mass index with a lower incidence of premenopausal breast cancer. And I think that's complex as well. It may have to do with the utility of mammograms for detecting breast cancers in obese versus non-obese premenopausal women, where the breast density is a lot different. I think it may also have to do with body composition as a better marker of metabolic health, especially in younger women. And so I think that is complex. But when you use body mass index as a general measure, that those are the associations that come out. Higher levels of body mass index or obese range BMI. And it's really part of the overweight range too. We see that the risk for breast cancer goes up once your BMI is about 27 or greater after menopause. That's hormone receptor positive breast cancer.
So again, just for the audience, we're talking about now the risk of developing a breast cancer, not that patient who has been diagnosed with a breast cancer. And when we talk about that risk, Neil, what should we be telling our patients in the primary care provider's office, in our churches, in our schools, in our magazines? What should they be looking towards in order to decrease some of that body mass index?
Yeah, it's a great question, because I think the first thing that we have to do before, we try to give advice or prescribe anything is understand that much of the obesity epidemic is related to the built structures around us, including neighborhood stress, our access to foods, how much our surroundings promote physical activity versus, using a car to get around, for example. And so I think that there are a lot of variables that are not directly in control of the individual. And I think that with that understanding, we can then more effectively address the recommendation of what to do about obesity to reduce cancer risk. And I say that because we always come at this not from the angle of judgment, right? We look at obesity purely as a risk factor, with the recognition that the deck is really stacked against us. We live in an obesogenic environment. It's hard to get away from risk factors for obesity. And so I think that recognizing that, one of the things that I try to discuss with folks is, what is your reality? What is your daily reality? What do you have access to? What do you not have access to? What is a behavior that's easy for you to strive for? What's one that has barriers and there's no way you could accomplish that? Or maybe when you're in your most ideal states, you think that it's doable. Those are the kinds of things that are not reachable goals. And so once we recognize that, I think it's a lot easier to get to a place of what's available to you. What do we know, or what might be available to you that you didn't know was available to you? And that's where we can provide resources. And then how can we work within that environment? And I think with that context, we know that at the very basic level, to reduce obesity, the most effective approach is calorie restriction. Easier said than done.
That makes so much sense, but sometimes very hard within ethnic groups. I know that where my parents came from, in a small village in Cyprus, calories were considered, something that was something to be proud of. The foods that were prepared, the foods that are still prepared, the foods that I've learned to prepare are not always the healthiest of foods. Although our Mediterranean diet is wonderful, but we do supplement it with a lot of meats and richness and sugared pastries and all sorts of things, and almost with a sense of pride. And it's really changing the mindset, educating our communities, on what they can look forward to if we don't change their mindset. And you talked about 13 different obesity-related cancers. What are some of those cancers?
Yeah, I think you raised a lot of really important points there. And so that's why I'm happy to do things like this with you, where we can raise awareness. So the 13 obesity-related cancers, I'll name several, maybe not all of them, but
Mhm,
I mentioned postmenopausal breast cancer already,
mhm.
endometrial cancer, prostate cancer, esophageal cancer, colon cancer, multiple myeloma, to pick out one that's not
Interesting. Mhm.
typically thought of, kidney cancer, thyroid cancer. And I would also add that, there are cancers that are not on the list, um, that there exists evidence that obesity is a risk factor. IARC used a very high standard to define an obesity-related cancer. There had to be multiple population-based studies with hundreds of thousands of people in those populations. And so that, it's a very high level of data, but I do think that it does leave off some other cancers that are obesity related. Even our own group, for
Mhm.
example, published data nearly 10 years ago now, that squamous cell carcinoma of the tongue, so tongue cancer, is related to obesity. And we had a very robust data set, but it was smaller than, and that's the only report, I should say.
That's
And so,
interesting. You always think of EBV-related squamous cell carcinoma of the tongue. One doesn't think about obesity, and there you go. You
yeah,
got that report there.
yeah, we got that report there. I learned from the head and neck surgeons that there's actually a plane of fat in the tongue. We were able to study that
Wow.
tissue from people undergoing tongue surgery for cancer. And we saw very similar things that we saw in the breast fat when it was inflamed. And so the mechanism really has to do, I think, with how healthy the fat tissue is.
Talking about fat tissue and white fat, and women who are diagnosed with breast cancer, how does that all interplay?
Yeah, so this is where I think we can start to be more precise about the way that we categorize metabolic health. Speaking of fat and adiposity, we actually reported several years ago, and this has now been confirmed by other groups and other populations, that even if you have a normal body mass index and you don't technically qualify as having an obese range body mass index, we found that if your body fat levels were above 30%, um, people in that group have more than doubling in their risk of developing breast cancer compared to those who have body fat levels that are less than 30% and a normal body mass index. Um, in other words, these are people with normal weight, normal BMI, whose doctors are probably telling them that you're metabolically healthy and you're not at risk for metabolic complications. And, ultimately an unrecognized risk of obesity-related cancers that's actually associated with amount of the body fat. So I bring that up because I think that, to answer your question, I think that really highlights that it's really the fat tissue that seems to be the
Mhm.
major contributing risk factor for the development and the growth of cancer once it's established. Um, what we found was that in the breast fat, if a person had an obese range body mass index, they were more likely to have inflammation of that fat tissue. And that fat tissue is, when it's inflamed, it becomes like a hot pad for cancer growth. It's essentially spitting out little inflammatory molecules, which are growth factors for cancer cells. And it's also generating estrogen. It's generating more estrogen, not that's circulating around in your body, but within the breast fat itself. And so you have this sort of microcosm of the perfect environment for the growth of hormone receptor positive breast cancer.
That word inflammation is fascinating, and what a pivotal point it is to really kind of dive into what's going on with, the metabolism and breast cancer and how it's moving forward. Can you talk to us a little bit more about inflammation and what we're seeing in adipose tissue in the breast? and how it relates to things like leptin and sex hormones and insulin. I know I'm throwing a lot at you, but I've got you for such a short period of time, and there's so much that I want to learn that my audience wants to learn.
Yeah, absolutely. All really relevant and important questions. I think that in terms of inflammation, it's been recognized for a long time that inflammation or chronic inflammation is a risk factor for the development of cancer. Part of the way that smoking tobacco causes cancer is through inflammation. Part of the way that liver cancer develops is related to hepatitis viruses that cause inflammation. And so that recognition of inflammation causing cancer has been around for a while. What is relatively new is the recognition that obesity causes a chronic state of inflammation. And I think that's important because it's not like when you cut your skin and you develop, redness and scabbing and scar tissue and all of that. That's relatively quick inflammation. And yes, some of those cytokines are still involved in chronic inflammation. But it's like if you were to take that process of having a cut and it healing, if you were to take that process and slow it down, I don't know, 1,000-fold, that would be the sort of low-grade smoldering inflammation that's happening in the fat tissue over years and years and years and years. And ultimately, that degree of smoldering chronic inflammation, just like a hepatitis virus or just like smoking, that can ultimately generate those cytokines or growth factors that stimulate cancer growth.
What an incredible finding and understanding if we could get this out to larger populations, because what you're implying is that this could be reversible.
Yeah, great point. And yes, it does appear to be reversible. We know that in the context of diabetes, for example, if somebody has diabetes, they typically have a lot of inflammation of the fat tissue in the abdomen. And as they lose weight and gain control of the diabetes over time, you start to see a reduction in the amount of visceral adipose tissue inflammation. Now, it would be logical then to think that that happens in the breast fat as well. And we certainly have mouse models where that has been demonstrated. As a mouse lose weight through dieting, it has less inflammation in the mammary gland fat. We have some data in humans from some dietary studies that have suggested the same thing, but we don't yet have large-scale data to indicate that. And that's why we have completed a clinical trial in which women have volunteered to undergo biopsies of the breast fat before and after the diet and exercise intervention, so that we can directly address that reversibility question. And I think ultimately we will show that you can reduce inflammation.
And what kind of diet and exercise are you looking at?
Yeah, so it's the intervention was primarily a weight loss intervention. And so we enrolled women for now with a body mass of 27 or higher. I know I gave this whole talk about how we should be considering metabolic health in a normal range, and we will. We have an upcoming trial that will replicate what I'm about to say in the normal hyperadipose population. But what we showed in this population of women, they were all postmenopausal with a body mass index of 27 or greater. We enrolled them on an intensive weight loss regimen, which was highly personalized plant-based diet, where all of their dietary intake was essentially not meat or meat product related, not vegan necessarily, but not meat itself. And that it also involved calorie restrictions. So we were restricting energy intake, we were changing the quality of the diet, and on top of that, prescribing exercise. So it was a precision exercise trial where we sent a treadmill to the home of everybody who participated
Wow.
and
Mhm.
prescribed exercise to the degree of weight loss that we were aiming for. So every week we determined what that individual's goal weight loss is for that week, based on the kinetics of the weight loss and the amount of calories that they expend doing their normal activities during the day. And we created a daily caloric goal for that individual, which we achieved, a caloric deficit goal, I should say. And we achieved that through this structured diet and exercise intervention. That was in the super controlled arm. And then in the less controlled arm, we essentially gave all the tools to everyone. You know, we sent them the recipes, we sent them the treadmill, but we didn't walk them through the math. We didn't calculate their daily needs and so forth, nor did we do daily structured exercise. We did more like monthly counseling calls to advise people on what kinds of exercise they should be doing and how often they should be doing it based on current guidelines.
And
And
just
then
for
it was, oh,
clarity,
go ahead.
these are patients that have been diagnosed with breast cancer.
Oh, yes, yes. Good
Mhm.
point. These are patients who are diagnosed with breast cancer, hormone
Mhm.
receptor positive, stage 1 to 3, and we're taking their adjuvant hormone therapy, which was essentially aromatase inhibitors.
And
That
these
was
were
the population.
postmenopausal patients?
Postmenopausal, yeah.
Okay.
Yeah.
Mhm.
And so in the less controlled arm, we, as I said, we gave everyone the resources and kind of guided them on what they should do. And then it was really up to them to do it themselves by the end of the intervention. And then we saw how everyone did.
Uh, Tell me a little bit, speak to a plant-forward diet, not plant-based, but a plant-forward diet. I've heard you use that term. It makes so much sense to me. Educate our listeners.
Yeah, absolutely. So that I use that terminology because we don't have, concrete data that one has to be vegan or 100% vegetarian to lower your risk of breast cancer. I think one can be very specific about their dietary choices and their dietary risks. And, when it comes to public health messaging, or for folks that don't want to invest that much mental energy into it, it can be helpful to be very, you know, dichotomous about your recommendation, right? So if somebody just tells me, you know what, just tell me what to eat, and I say, but don't give me the details, then I would say, try to eat as much of a vegetarian diet as you can. But luckily, you and everybody who's listening is sophisticated and wants to know more detail. Not that there's anything wrong about not wanting to expend mental energy on a more general recommendation. But when it comes to more specific approaches, I do use the plant forward terminology, which refers to an intake of about a goal intake of about 80% of what you eat coming from plant-based sources. And then if you do eat meat, the remaining 20% being lean, minimally processed meats. And I think that is consistent with the data where we see that, interventions that recommend a Mediterranean diet, as you brought up earlier, or a low fat diet, or a diet that really is consistent with current dietary guidelines, it tends to be a plant forward diet, yes, with a little bit of meat, and that seems to be very healthy in terms of balancing risk.
But it also makes it attractive for that person to want to follow it because it's not so restrictive. And they may eventually lean towards more plant forward, plant-based. But it's a good segue to start a conversation and bring a patient in to that arena where they're not blocked by it. Let's talk a little bit about um, some of the things that make us nervous when we have a patient with breast cancer, sometimes because we don't know the data or we don't know how to interpret it. One thing that I hear over and over again, and I know that you're going to predict what I'm going to bring up to you, is things in the diet like flaxseed, things in the diet of phytoestrogens, can you speak, just a little bit about that? Because I think we as providers don't understand the data, and certainly patients need to benefit from, you know, some good hard facts
Yes,
as we know
absolutely.
them.
Yes, absolutely. I think part of the issue is a lot of the data regarding specific foods or specific nutrients comes from observational data. And as you know, there's a lot of potential caveats and flaws and confounders when you look at observational data. It's really hard, and you can do all kinds of statistical maneuvering and modeling to really try and isolate a single nutrient and its effects on a
Mhm.
person's health. But at the end of the day, you can't eliminate all of the potential confounders. And it becomes the more specific you get, the more challenging it gets to really isolate that effect. So if you start more broadly and you say, oh, I'm noticing that people who eat a plant-forward diet have lower rates of cancer. That is the most impactful then, or likely to be the most impactful intervention, is to say, okay, we have the most robust data for this general eating pattern. Once you then start to say, well, okay, so now if you eat, a potato that's starchy, that's going to increase your risk. If you eat, a soybean, now I'm worried about, phytoestrogens, and that's going to increase your risk. The problem there is that there are many flaws with that because you've really tried to narrow it down to a singular ingredient or singular food, and now the risk for confounding by other factors is tremendous, and certainly more than what it was when you looked at the general, eating pattern of plant forward. And other issues are that because now you've done that, you've increased the chances that either you're going to find false associations or you're going to find really weak associations. Or if you do find an association, it's under the umbrella of the broader recognition that that generally healthy eating pattern is actually healthier. And so how can, yes, one unit of that broader, diet be might be more less healthy, but it's not eliminating the effect of generally eating healthy. So I say all of that because yes, we don't want somebody eating, potatoes, starchy vegetables for every single serving of vegetable that they consume. But if you generally eat a diversity of foods under a plant-forward diet, that's why we use the phrase eat the rainbow when it comes to picking out your fruits and veggies. If you eat a little bit of everything, then you're getting all the nutrients that you need in the synergies that you need them. Again, if you isolate one nutrient, we don't know how it's going to act if it doesn't have the synergy of the whole food in which it is supposed to be delivered. And so that's why we say a minimally processed, whole food-based, plant-forward diet, which is most likely to get you all the nutrients that you need. And if there's a problem with any of those nutrients, it's likely to balance out by the positive effects of the other nutrients. And that's why generally, go ahead.
No, no, no. I remember an excellent study in China where women that were diagnosed with breast cancer were put on placebo versus a high soy diet. And it was actually that high soy diet that was the optimal, outcome for those women. And yet, we look at those studies and how do we transfer them to Western cultures where we do not go anywhere near that high soy diet. But, is soy okay? I usually tell my patients no more than 2 to 3 servings a week. Moderation, moderation. What do you tell your patients?
Yeah, I mean, I generally do subscribe to the moderation philosophy. That being said, I would say soy is definitely okay. There's so much data now that, and including the data that you just cited, Maria, that indicates that soy is not only okay, but it might actually be protective.
Mhm.
Again, when we look at the population data, as you said, there's a lower rate of cancers among people who report a high soy intake. And biologically, we have to remember that actually some estrogens are beneficial for lowering the risk of breast cancer, not unopposed estradiol, which is the most common form of estrogen.
Right.
Um, but there are some data to suggest that the mix of estrogens is important. And so when somebody says phytoestrogen, I don't know if they're referring to estradiols that are harmful or if they're actually referring to the more
Right.
protective estrogens.
Right. So important, so important. And now in the world of semaglutide, everybody's injecting, they're losing weight. And yes, the brain is being told that you don't need as much food, the satiety center is triggered. Um, what I am seeing in my patients is that, yes, there is weight loss, and that makes me happy on multiple levels. But what are they eating in that diminished caloric environment? Is it healthy plant forward, or are they eating just a small fried food diet that is really not good for them, even though they've lost weight with these injectables? For me, it's confusing and um, concerning on some levels, yet optimistic on other levels.
Yeah, I think you raise, really important issues. I agree with you. I think that the weight loss drugs are an incredible tool to help people lose weight. And,
Mhm.
the amounts of weight that they induce are the levels of weight that we've been hypothesizing for a long time that are needed to lower people's risk of cancer or cancer recurrence. And those levels can be a real challenge. Some data suggests that you have to lose at least 10% or more of your weight if you're in the obese range to lower your cancer risk. And so that can be a real challenge. These drugs help people lower weight on average by up to 15%. Some
Mhm.
reports even more than that, up to 20%. So the amount of weight loss is tremendous. But I agree, we're really in early days in terms of what that means for cancer and cancer therapy. I will say that there was one study that looked at a registry which included over 15 million people, so a very robust data set. And it showed that people who have type 2 diabetes and who take these weight loss drugs have a lower
Or
risk of,
diabetic drugs. That's what they were designed for. Yeah.
yeah, yeah,
To bring down
exactly.
that hemoglobin A1C.
Yeah, yeah. And so if they take these weight loss drugs, they have a lower risk of almost every obesity related cancer, almost everyone. Now, the list suspiciously excludes breast cancer and
Mhm.
postmenopausal breast cancer. They did not find a reduced risk of breast cancer in folks who took those drugs. And I think it's because, as you said, Maria, they focused on patients with diabetes. And so these drugs were prescribed not necessarily as weight loss drugs. You can prescribe them to treat people's diabetes, which induces a less amount of weight loss, more in the 4 to 5% range. But when weight loss is the goal, then you prescribe it at a different dose, and that can induce a lot more weight loss. So maybe these folks weren't achieving enough weight loss to lower their breast cancer risk. We also don't think it was a long enough follow-up time. So I think these drugs can be tremendously helpful. But that being said, I agree with you. It doesn't mean that they erase the negative impact of the nutrients that you're
It's
eating.
not a free pass.
Yeah, that's
It's
right.
not a free pass. It's not a free
Yeah,
pass to McDonald's.
right.
Yes.
That's right. That's right. Yeah. I mean, because we're still harming our bodies in the same ways that are not all related to the amount of weight that you carry. And then the issue too is when people stop these drugs, we know that the weight comes right back on. And what does that do to cancer risk when weight goes up and down? But people can be successful. And many of the studies in the diabetes literature and even in the cardiovascular non-diabetes literature have paired these medications with lifestyle modification and lifestyle intervention. And when someone successfully does that, they can induce a lot of weight loss and then maintain that weight loss if they've been doing that lifestyle modification from the very beginning. The real challenge is when you stop the drug, all the cravings come back. The food cravings come back. So if you've trained yourself while you are on the drug to
Mhm.
eat a specific way and to exercise a specific way, you're much set up much more to succeed at ignoring or looking past those cravings once they come back than somebody, who didn't modify their lifestyle and has now stopped the drug.
Yeah, I love that. I love that because, there's an opportunity here to actually do something positive for oneself, outside of the cosmetic, outcome. And certainly, a patient with diabetes, there's so many multiple benefits that they're going to receive. But it's really during that time when you have a smaller um, ability, a narrower ability to change how you tell your brain that you now are full and not needing that second helping and not eating in between. But what is it that we are training ourselves? So at the end of the day, we have a good, healthy diet with less inflammation in one's breasts, that smoldering, hot, inflammatory component. Let me tell you, the way you described it scared the bejesus out of me. But to understand all of that and take advantage of it and move forward, um, I think one of the issues that always concerns me is a lot of my patients who are on adjuvant endocrine therapy, a therapy that is supposed to decrease the number or potential for metastases, decrease the risk of recurrence in a distant site, as well as the remaining breast tissue, increase one's survival. And yet, um, I worry that in those patients that are on aromatase inhibitors, if they are not paying attention to their caloric intake and their weight slash obesity, that we may not be gaining the benefit from our adjuvant endocrine therapies. Can you speak to that? The aromatase that is formed uh, in the setting of obesity and in the breast tissue, yet we're giving aromatase inhibitors to decrease the risk of recurrence. Can you speak to that, Neil?
Absolutely. That's such an important point because we think that's one of the mechanisms through which obesity promotes the recurrence of breast cancer. Um, there are data when we look back at the ATAC trial, right, which was the seminal trial that proved that in postmenopausal women, aromatase inhibitors are a little more effective than tamoxifen for preventing breast cancer recurrence. Now, what was interesting is when the investigators went back and they looked at that data, what they found was that in women who had obesity, that benefit of the aromatase inhibitor over tamoxifen was erased. There was no additional activity of the aromatase inhibitor, and I think that does raise the question then, okay, what is countering the beneficial effects of these aromatase inhibitors that we're prescribing in women who have obesity or higher amounts of body fat? And to that point, I think you're absolutely right. Our data shows that the inflammation that occurs in the breast fat, it can then stimulate the production or the gene that is responsible for the production of aromatase. And aromatase, of course, is the enzyme that's responsible ultimately for the production of estrogen.
Hmm?
So that you're absolutely right to point out is really what we think is the mechanism as to why having too much fat tissue, having inflamed fat tissue, is countering the effects of the aromatase inhibitors.
You know, I draw pictures in my clinic to tell patients what the mechanism of aromatase inhibition is. And then I say, I need for you to help this happen. You know, it's
Mm.
just not me prescribing a drug. I need for you to help this happen proactively for oneself. Um, let me just end our time together by asking you a question that I have not asked you before. I didn't even realize I was going to ask it. What about the flip side? The patient that comes into you that is way thin. Um, can you comment on that? I'm not even quite sure how to ask the question. And whether it's a younger patient who's premenopausal, and we're talking about patients diagnosed with breast cancer, or the older patient that is below the ideal body mass? Are there risks to that?
Yeah, it's a great question. I'll start in the post-diagnosis space. When somebody has been diagnosed with breast cancer, there's sort of a U-shaped curve relationship between body mass index and the risk of recurrence. So we certainly know that a higher BMI after diagnosis of breast cancer increases the risk of breast cancer recurrence. And that applies to all breast cancers, triple negative, hormone receptor positive, premenopausal, postmenopausal. Those data are pretty
Triple
strong.
negative, something that we need to point out. Triple negative, yes.
Triple negative, absolutely. So we've been talking a lot about risk, but in the post-diagnosis setting, obesity increases the risk of recurrence for all types of breast cancer. And so when we look at it that way, and we look at the flip side, we also see that people who have, a lower BMI, underweight range, their risk of recurrence seems to be higher as well. The data are a little less robust, but I think it's because, again, at the population level, having too low of a body mass index might be indicative of some other medical diagnoses or medical problems that could increase risk, but it could also indicate sarcopenia. And sarcopenia is essentially a state where you don't have enough muscle mass. And that has problems as well. And sarcopenia can actually occur in underweight individuals most commonly, but it can also occur in obese individuals. That's called sarcopenic obesity. And that's essentially where you don't have enough muscle mass. And if you don't have enough muscle mass, skeletal muscle, you're not making enough insulin. And now your insulin metabolism, you probably have insulin resistance because you're not making enough insulin. And so that can raise the risk of multiple obesity-related cancers as well, which is why ultimately I think we should be using body composition and the amount of fat tissue you have and the amount of lean mass that you have to more precisely determine an individual's risk of cancer.
Neil, you are absolutely one of my most favorite people as not only a physician because you're superlative. Patients love you. You speak their language, and it could be multiple languages. And I'm not talking about, you speak the language that patients understand and they get what the goals are, and you discuss goals with them. But I will say that as a researcher, as a colleague, as an educator, you have brought so much forward to my education, my patients' education, and I am proud that you will be receiving the Advocacy Award at the Breast Cancer Symposium in October of 2025. So well deserved, an honor that I'm thrilled to give you, and I thank you for the time that we have spent tonight. Truly. And I hope that the audience who comes in on this particular educational video gets as much out of it as I have. And I promise you more of these quote unquote live podcasts as we develop and understand more information from our scientists and researchers like Dr. Iyengar, who bring all of this into the clinical arena for all of us to share with our patients. Thank you very much, Neil. I wish you good holidays and good night. And this series should be live by February for everyone to participate and listen to. Thank you again.
Thank you so much, Maria. It's my honor.